Okay, thank you all, and welcome back to those who are in the first part. Welcome to those who are now attending the second part of this workshop series on criminal justice and behavioral health. My name is Jenny Simpson, and I am in the Office of Behavioral Health Equity and Justice at the Substance Abuse and Mental Health Services Administration. We're a part of the U.S. Department of Health and Human Services. During the last session, if you were here, we heard from your peers about screening and assessment. In this workshop, we're going to hear from your esteemed colleagues on individuals with complex health needs who are cycling between multiple service systems, including the criminal justice system, behavioral health systems, and social service systems. We know that those individuals are often coming repeatedly through your system and others, but they're achieving really poor outcomes, both in behavioral health, their social outcomes, as well as criminal justice outcomes. Many of these individuals have mental and substance use disorders, may experience chronic homelessness, and have comorbid physical health issues. So today, again, we're going to hear about how our presenters are identifying and addressing the needs of those individuals. So just a couple of housekeeping items. Before we begin, please silence your cell phones. And after the workshop, please fill out your workshop evaluation. And I'll ask that you save your questions till the end. Sorry, if I'm not loud enough, just raise your hand and let me know. Please save those questions for the end because we will have a Q&A session. So let me do a brief introduction of our speakers today. So first we will hear from Sheriff Vic Regalado. Sheriff Regalado is from Tulsa County, Oklahoma. Prior to being elected sheriff in 2016, he spent 22 years with the Tulsa Police Department. Sheriff Regalado is responsible for maintaining law and order within the borders of Tulsa County and commands a full-service law enforcement agency of over 600 personnel that includes detention, court services, and operations divisions. Following Sheriff Regalado, we will have Ms. Randy Moore. Ms. Moore is the division chief for the Hudson County, New Jersey Division of Housing and Community Development. In her role in Hudson County, she has spearheaded new initiatives and implemented innovative programs to improve the way housing and services are provided to homeless individuals and families in Hudson County. In addition to Ms. Moore, we also have Mr. Frank Mazza, who serves as the Program Director for Community Reintegration in the Department of Corrections and Rehabilitation for Hudson County. He facilitates the program that provides integrated care coordination for people with substance use disorders who are leaving the jail in Hudson County. We welcome you and thank you for being here. So now I'm going to just hand it over to Sheriff Regalado.
Thank you. Glad to be here. Just a little forewarning. I was called about a week ago to do this presentation, which I readily accepted. I always appreciate being able to get out and talk about what we're doing in Tulsa County and all the good things, and especially in terms of mental health. But then a few days later, they told me about a PowerPoint. So forewarning, I don't do PowerPoints. I go off the cuff, and so if you start seeing me talking about something that's not on that screen, don't worry about it. We'll get to it, I promise. Again, I certainly appreciate being able to talk in front of you today, and I hope to give you a perspective from a law enforcement standpoint, but from a fresh and new law enforcement standpoint, because I'll tell you, prior to becoming sheriff, I had a lot of years of experience in a multitude of areas in law enforcement, and mental health was not one of them. And when I took office in Tulsa County 2.5 years ago during a special election, there were a lot of problems that needed to be dealt with. And then on top of that, they informed me that now I had oversight of a brand new mental health pods that were being constructed in our jail. So that was a busy time 2.5 years ago, but we've made a lot of progress. And I hope to get into how we did that and And then, of course, at the end, answer any questions that you may have. Just a little bit of background. Tulsa County is about 605,000 people. The Sheriff's Office serves about half of those. Tulsa Police Department serves the others. Our jail is a 2,000-bed facility that is equipped with a full-service hospital, everything short of major surgery. And now we also run a mental health facility within the jail. So it's quite a task. And we'll get into some of the complications and some of the problems that go along with that. Without further ado, today our mental health care system is fragmented, underfunded, and difficult to navigate. Mental illness often results in a vicious cycle of poverty, homelessness, and incarceration. So I think that we've all heard that, and I can tell you that this is not something that just happened. This has been a long time coming, and I think now we're waking up and finding ourselves in crisis mode. I know we are in Tulsa County. And I can remember in 1993 as a rookie police officer receiving calls, routine calls over and over again about the same individuals in my beat. And as a rookie cop, I would respond and they would always be the same. Individual talking incoherently, screaming, causing a disturbance in front of a business, laying in the middle of the street. And when I would get there, I'd realize real quickly that there wasn't criminal intent, but as a rookie cop, at a time that we did not have mental health training, my solution was jail for the misdemeanor offense that occurred during that time. And time after time, as I got experience, I realized these are individuals that are suffering from mental health issues and illness, but there was nowhere to go. One of the larger mental health facilities in Oklahoma had just recently closed, and we literally had nowhere to take people except the jail. And this occurred, again, I realized it in 1993, and as we progressed, we started having the problems in the jail, because the jail obviously didn't have any of those facilities or training or experience with the mentally ill, and so it became that revolving door. And today, jails are now the largest providers of mental health services in the country. There's something inherently wrong with that, because we are not mental health providers. And we do our best in law enforcement, and I think the previous sheriffs that was just up here a little bit ago touched on it a bit. Law enforcement are not mental health professionals. And we'll get into that here in just a moment. But I think it's critical and imperative that we understand that as a whole, that attacking and addressing aggressively the issues of mental illness in our society is all of our problem. That's why I hate PowerPoints. So, some sobering statistics about my beloved state of Oklahoma. Anybody here from Oklahoma? Good. Usually they get mad at me when I start talking about these things. And they're not easy to talk about, especially about my home state. But if we don't face the issues that are in front of us and address them and realize them, then how can we move forward? So the CDC reports Oklahoma ranks in the top 10 in suicides per year in the United States. Oklahoma has the highest incarceration rate in the world, men and women. So we had the dubious distinction of having the highest female incarceration rate in the United States. We were number 2 for men, and now we have elevated ourselves to number 1 in the world. So let's put that in perspective. 1,079 out of every 100,000 people in Oklahoma are incarcerated. Number 2, El Salvador, with 619 per 100,000. If that's not a sobering statistic, I don't know what is. I'm going to end up fat fingering this little control thing here. So, Tulsa County, what was our response to this? Well, let me move forward some more sobering statistics if those first ones weren't enough for you. Women in Oklahoma jails are much more likely to suffer from mental illness and substance abuse than men. Approximately 70% of incarcerated women have an actively managed or serious mental illness compared to 44% of incarcerated men. Now, how did we address that? How are we addressing that? In Tulsa County, as many of you have heard already, the Stepping Up initiative in 2014, We formed the Outside Inside Collaboration for Justice, OICJA, which was comprised of law enforcement, social services, mental health services, private and public partners. And they went across this country looking at best practices and figuring out how we wanted to formulate the model in which we have put into place now in Tulsa County in terms of addressing mental illness in the jail. In 2015, Tulsa County adopted the Stepping Up Initiative, focusing on mental illness in the jail. So the one thing I want to talk about that, it's very easy to simply say we've adopted the Stepping Up Initiative, or any other initiative for that fact. But what's critical, and I think in the Stepping Up information, what's critical and number one is that the leadership has to accept it and decide that this is going to be something that they're going to gear all our resources and energy and everything else towards, because simply saying it and doing it are two different things. And I see it in many different counties and places, even in my state of Oklahoma. It's nice to say that we've accepted this and we understand it and we're going to move forward, but doing it is a whole nother issue. I'm sorry? Can you guys hear me? Okay. Raise your hand if I start to drift away. So the goals: reduce the number of people with mental illness booked into the jail, shorten the average length of stay for people with mental illness, increase the percentage of connection to care for people with mental illness in the jail, and lower the rates of recidivism. So I can tell you that number 3 is probably the most critical. And I've heard it talked about previously and everywhere else that I go. What service are we doing if we are simply identifying people with mental illness in the jail, and then when they get out, we have nothing to do with them, and there's no services available? That's, to me, I believe that that's the critical component of addressing mental illness in the jail and attacking those recidivism rates and the average length of stay and reducing the number of people with mental illness in the jail. And so as we moved forward, the Tulsa County Jail and detention staff do not do the medical or mental health. We have a medical provider, a vendor, if you will. And when I came into office, we were averaging around 9 to 10 deaths in the jail a year. There was a real serious disconnect between that current provider and the jail staff, as well as the sheriff's office. And I can tell you that if you don't have a partnership that consists of transparency and consistent communication, you're going to head down the path that my agency did. And that resulted in multiple lawsuits that resulted in millions upon millions of dollars in settlements. And I know that I know there's got to be some county commissioners here. That's something that we all want to avoid. So when I came in, we made a change of our medical vendors. And what we did is we sat down and we said, what is critical to us? What do we want out of our medical provider? What do we expect? And, you know, when we decided and created that partnership and moved forward, we saw a lot of success and have so over the last 2.5 years, to the point that now we've had 2 deaths in our jail, 1 natural, 1 suicide in the last 2 years. And I truly believe that it is a change of culture, but most critical, that partnership and that understanding and the same goals shared between your medical providers and the jail. Moving forward, our mental health pods, they opened in 2017. The max capacity for the new part was 100. We still have our quote-unquote older part of our medical unit, which is in the, mental health unit, which is located in our medical portion of our jail. It consists of levels 1 through 4. So number 1 is for those that are suicide is imminent. They have to be watched 24/7, eyes on by detention staff. Number 2 is for those that aren't suicidal but still have problems taking their medication, their hygiene lacks, communication skills still aren't there. Level 3 is for those that are now being able to take their medications on their own. They're responding to treatment, to therapy. And then number 4 is the level right before they are put back into general population. And I'll show you some pictures here momentarily. Initially, the jail, prior to coming in, had trained only the detention staff that was going to work in the mental health pods with CIT, crisis intervention training. We have now since changed that, and that certification occurs in every academy that we put through, with the ultimate goal of everybody, every detention staff member in the jail will be CIT trained. And one of the critical components about the CIT training, to put all that into perspective, because we hear a lot about CIT training, what does it really mean? Well, what it has meant to us in Tulsa County is reduced wrongful death suits, more appropriate use of force, reduced injuries to inmates and detention staff, increased knowledge and awareness of mental illness, reduced stigma, and increase in officers' confidence. So I think that number 4, if you'll increase knowledge and awareness of mental illness, I think that's the critical component of CIT training, because I've seen it time and time again, and I'll give you an example that really shows what that means. Is we didn't have, again, law enforcement are not medical health professionals. We're not mental health professionals. You know, the extent of my mental health vocabulary was cuckoo, crazy, and nuts. And, you know, and so we are really in the catch-up mode, and myself included. And so when we have that training and ability to recognize and understand, that's where you see the success in. And I'll tell you, one of my favorite examples is this. We had a female offender that was awoke by one of our detention staff. She immediately jumped up, took a fighting stance, and was getting ready to attack the detention officer. The detention officer, who had been trained, was able to recognize that this individual was in some sort of psychosis, and that the intent to fight her was not criminal or nefarious in any way, but simply something was going on. She was able to step back and first identified herself and said, hey, I'm detention officer such and such, you're okay, relax. At that point, the offender appeared to snap out of it, kind of looked at her and said, hey, I'm sorry. You need to understand that as a child, my stepfather used to stand over my bed, wake me up, crawl in, and then repeatedly rape me throughout the night. And she's lived with that trauma throughout her life. And so what came of that? Well, what came of it is that after thanking the offender for sharing that intimate detail about her life, they came up with a way to wake her up so that she could avoid getting up and assaulting our staff. Decreasing assault on staff, decreasing injury to inmates and staff, and having an understanding through training accomplished all of that. Just a blueprint of our mental health pods. As you can see at the top, we have a laser pointer. At the top are our level 1s, to the left, or I'm sorry, to the right, level 2, and to the left is level 3. And then that big structure to the left of that is our level 4. And I'll show you some pictures here momentarily. There you go. That's of level 1, 2, and 3. As you can see, there's a lot of ambient light, pastel colors that bring a soothing nature to that particular facility. It's open, and it all goes towards the therapy and the treatment of those individuals suffering from mental illness in our jail. Another look, these are, as you can see right here, the individual cells are the ones that we place level 1 inmates in, and our detention staff that puts the eyeball on them 24/7 sits right there. And then there's the level 4. As you can see, it's kind of got a college dormitory feel to it. It's wide open, lots of visual and ambient light. There's TVs in different portions of the level 4, and our detention officer sits right there. We've had very few assaults on staff. I mean, I'm talking minimal in either the levels 1 through 3, as well as number 4. So identification and assessment. I know a lot of time was spent in the first portion of this, so I'm going to briefly go through it. But we do have a questionnaire and a brief jail medical assessment in which we tried to determine previous care, mental health illnesses, medications, whether they're suicidal or not. And again, more often than not, these individuals are not always truthful. And being cognizant of that, we've invested in what's called My Health software, which gives us access, statewide access to individuals who have received medical and mental health treatment and the history of that in the event they're not truthful during the assessment. That's just another tool for us to be able to identify and assess inmates in our jail. Furthermore, we also created a 1-800 number within our jail that we, through the media, informed the general public that if you have a loved one who suffers from mental illness, with the understanding that they're not always truthful or forthcoming about it, you can call this number. We staffed it with an individual Monday through Friday, 9 to 5, but it also has a message service. And you can call and say, hey, little Johnny, my brother, is in your jail, and if he didn't tell you, he's currently under these type of medications and suffers from this type of mental illness. And again, it's just another avenue in which to identify, assess, and treat those individuals in our jail. At the Tulsa County Sheriff's Office, we have a unit that's called the Mental Health Unit. It's comprised of deputies and supervisors whose main directive is to work closely with the mental health courts. They provide mental health pickups, they identify repeat offenders, they do welfare checks, and they transport previous inmates to medical appointments on the outside as part of that outside of the jail treatment program that we try to encourage our inmates to become involved in. And I want to speak just a little bit on this group because they are a fabulous, outstanding, committed group of deputies. And I'll tell you, you can't just bring anybody into it. It takes a certain personality, it takes patience, it takes understanding, it takes above and beyond CIT training in terms of education, but it really takes a deputy that has empathy, sympathy, not only for the individual suffering from mental illness, but their families, because that stigma, although we're getting better, that stigma is still there for many of these individuals, especially their families. They drive unmarked cars when they go to pick up these individuals suffering from mental health illnesses on their pickup orders, and they try to do it in the most respectful way possible when they do that. But even that being said, last year, unfortunately, we had a shooting involving that unit where they were forced to shoot and kill an individual that was suffering from mental illness. And here's where the disconnect the reason I welcome these type of speaking engagements, not that I'm an expert on mental illness because I am not, but what I hope to accomplish is to educate the general public, our elected officials, law enforcement, that there is still a difference, a disconnect in terms of mental illness and how law enforcement is sometimes forced to respond. So in this particular incident, this individual, they had been looking for him for about a month on a mental health pickup. They had made contact with him on 3 different occasions. Unfortunately, in each of those occasions, he had barricaded himself into an apartment, a house, or some other structure, and said, hey, if you come in here, I'm going to shoot you. On a couple of those occasions. On the 3rd one, he said, if you come in, I'm going to kill myself. Okay? This is a mental health pickup, not a crime. So we're not going to force the issue, which we did in the past. Years ago, we would have said, okay, we're coming in, and what we saw were people killing themselves or forcing us to kill them. They backed off and continued waiting for the opportune moment to grab that individual and pick him up so that he could get the proper treatment that he needed. He had stopped showing up to his treatment, and mental health court had issued a pickup order for him. Unfortunately, on the day of the incident, the mental health unit was actually out looking for another individual. When they saw him, he was in the middle of the street holding two very large, and we're talking very large, butcher knives, and walking down the street yelling and screaming. It was during the day in the middle of a neighborhood where there were still kids outside, people outside, and he continued walking. They approached with a loudspeaker at first, identified themselves, called out his name because they had a previous relationship with this individual, as they do with many of the people that they help. And long story short, he continued on and was getting ready to go into a convenience store that was occupied by several people, still holding the knives in a very aggressive manner, and unfortunately were forced to use deadly force at that point in time. Now, the part that is most concerning is that, one, I can tell you from a personal standpoint, going back to the type of people that work in this unit, they were upset, not at the fact that they had to make a deadly force decision. They knew that going into law enforcement, that that's a reality sometimes. What they felt bad about is that they weren't able to get that individual to the help he needed. They knew that he was suffering from mental illnesses and did everything that they possibly could to get him that treatment, and were unable to, unfortunately. Two, there was some rioting, there was some misinformation, and then a lawsuit came out of this whole situation. And the reason for the lawsuit, not the shooting itself, but the accusation that these deputies did not do all they could to get that individual the help he needed before the deadly force encounter. And again, lawsuits are going to happen in my world. They happen all the time. But, and we'll deal with those, and we'll deal with this one. And I think I'm 100% confident we'll be very successful in it. But the disturbing nature of this is that now there are people, with the information that was put out, there are people that think, hey, cops are just randomly shooting people who are in psychosis. And we've heard those stories across this country in the last few years. And whether or not that's true, what I am confident in saying is that the overwhelming majority of those incidents, I can assure you that law enforcement, in particular this incident in Tulsa County, they did all they could under the circumstances. And these were very well-trained deputies, not just your average patrol deputy who has CIT training and completes the yearly mental health as is standard for CLEAT certification in Oklahoma. So, understanding that we have a component and a responsibility inside the jail, we also have that outside of the jail. And in keeping that in mind, we've also, the OICGA actually, that's why I hate these things. Okay. Created an app that, and I think, did I have that just previously? There you go. We created an app that www.freescreen.com, which law enforcement can download. It's an app that provides them screening questions and definitions, assessment procedures, placement resources, and that's critical. Placement resources is critical. And then medications, and helping them identify what type of medications, when an individual says, hey, I'm on this, they can immediately look that up and go, oh, okay, well, that deals with schizophrenia or depression. And so we've equipped not just Tulsa County deputies, but have made it available to all law enforcement to download. And that's one of the things that I also would like to get across is don't keep all these wonderful things to yourselves, share them. Share them, network. You know, I come to these two for another reason, and that's also to learn, because we don't have all the answers. What we're currently in development is a crisis response team that will not only work within the municipality of Tulsa, but Tulsa County as a whole. And what we hope to get to is a one-stop shop out in the field. And that's going to be a specially equipped vehicle that we're currently trying to get right now through grants and other means. And it's going to be occupied by law enforcement, mental health, medical, and fire. So you're going to have your one-stop shop. And what we hope to to utilize this team for is that when a patrol officer starts getting those repeat calls that I kind of described to you back in 1993 that I was getting, and we still 20 some odd years later are still getting, now that patrol deputy can call this team. They can go over there and are equipped to either provide medical, mental health service, I mean, everything under the sun. I'm getting a 2-minute warning. Everything under the sun, which alleviates and allows our deputies to go out and do what they've been trained for, and that's handling calls for service in the criminal side. So believe it or not, it sounds easy. Hey, vehicle, staff it with these agencies, and let's do this thing. There's a lot of logistics that need to be worked out. When you start talking about interagency cooperation, that in and of itself is a nightmare at times. But we're working through that, and we hope to establish that in the coming year. So the last, and certainly not least, whose problem is this? I hope after this conference, the one thing you'll take with you, it's all of our problems. It's the judicial, it's law enforcement, community-based providers, private business, and faith-based groups. Those partnerships need to evolve, and we need to continue to facilitate those and work hand in hand in addressing mental illness in our society, in our jails, our neighborhoods, our hospitals, and most importantly, having a unified front when we start talking about approaching our legislation and the cuts that have occurred, specifically in my state, to mental health services. And I think that you've probably, and I'll end with this, you have probably gotten statistics on what it costs to house an individual with mental health in a jail, which is approximately $23,000 in Tulsa County, as opposed to the $5,400 for that same inmate in mental health court, which has proven to improve unemployment rates, decrease jail days, and decrease inpatient hospitalization days. So we win from a fiscal standpoint, but more importantly, we win from a humane standpoint. I think my 2 minutes are up. Thank you very much, and I hope I can answer any questions moving forward.
Good morning. So my name is Frank Mazza. I run the reentry program for the Hudson County Department of Corrections and Rehabilitation. This is Randy Moore, who is Hudson County's Community Development and Housing Director. And we're going to talk about a program that we developed together that targets the most frequent users of our public assistance system, our healthcare system, our jails, our shelter system. And just sort of how this reentry population and the homeless population, there's a huge overlap, and that this population truly represents sort of a burden, or they have needs across all domains. The stakeholders are represented by all the public and private systems of support, and how collaboration is truly needed to make an impact on this population. So we're going to start with what Hudson County looks like. So we're a large county in population. We have about 675,000 people. We have 12 municipalities. We're located right across the river from New York City, from Manhattan. So geographically, we're one of the smallest, but we are one of the most densely populated counties in the United States. So I'm gonna let Randy talk a little bit about what she does.
So again, Randy Moore, I'm the division chief for the Housing Community Development Office for the County of Hudson, and we are basically charged with administering the federal funds for affordable housing and community development, and also really the lead in ending homelessness for the county. And so in that role, we lead the continuum of care, which we get about $6.5 million a year in federal funds that goes directly to our homeless providers. The main focus of that is on permanent supportive housing and permanent solutions to homelessness. Not so much the shelter side of things, but making sure that we're permanently ending homelessness. And through that, over the last 3 or 4 years, we created a coordinated entry program, which is something that has been required by HUD but also makes a ton of sense. So the way that it used to work in our community, if you were homeless, you could show up at any door, look for help. If they had a bed, if they had room or an opening in their program, they could take you in. It may or may not be the best program for you, but they just happen to have an opening, or they'd put you on a waiting list. So what we've done is shifted so that we have one nonprofit agency who serves as our coordinated entry group, which essentially does an assessment of any individual experiencing homelessness through the shelters, through outreach on the street, make sure that they are scored using the same assessment tool, and put into a database. And anytime an opening comes up in any of our housing programs, they are taken from that list by order of priority based on their vulnerability. So we've seen an incredible shift in how we're providing housing and services and making sure that those that are needing it the most are getting it. That in itself is not going to end homelessness, because we obviously need more housing. We're in a very expensive community where the rents are very high and it's quickly changing, and lots more people moving in willing to pay higher rents. And so we're still seeing an increase in homelessness and a lot of housing instability, but this has really shifted the way we do housing and really improved things. So a lot of our partnership has come out of the need for more affordable housing and recognizing the overlap in our populations.
So, like I said, I work for the Hudson County Department of Corrections. I work for the jail. Half my staff works for welfare. Half of my staff works for the jail. At a 2,200 bed facility. And the first thing, in 2008, we had they're county commissioners, they're called freeholders in Hudson County. And he asked our warden, Oscar Avilas at the time, what he was campaigning. He was in a neighborhood where a woman had just got out of jail, and she said, I just got out and I'm gonna go back soon. And the freeholder said, well, why is that? And she said, the jail did nothing to prepare me for what life's gonna be like when I leave. The freeholder challenged our warden at the time and said, what are you doing? And it was sort of foreign. Generally wardens view corrections as what happens within their four walls, and having reach and impact in the community was a little foreign. It's more of a public safety institution. Wardens aren't judged on their recidivism rate, right? Wardens are judged on keeping people safe in their facility, delivering services, and then sort of opening the door, letting the clinical world, the housing world, and all these other worlds take it from there. The issue is we're a local county correctional facility. So the reason why people, in large part, are coming to our jail is simple, right? So we have a large chronically homeless population that are either living on the streets or couch to couch. They have mental health disorders. They don't have access to treatment, or they're not tapped into the primary network of care where they're routinely taking care of their chronic issues. They have addictions issues, and they're living in areas that have a high police presence. So you're talking about a homeless population that's symptomatic, that are exposed to frontline law enforcement, and they're exposed when they're in symptomatic and in states where they're using drugs, which all speaks to a huge potential for negative interactions with police officers. So the problem is, jail isn't sort of the target for this population. Their behaviors aren't driven by criminal intent. The behavior is driven by these addictions and illness issues. So with the lack of clinical options, and our frontline law enforcement would love to have other options, but the jail has become the de facto mental health hospital. The jail has become the de facto residential substance abuse treatment program. So what our warden did is he understood the need of his inhabitants, and he sort of looked to redefine what the jail was. We have a mental health facility in our jail. We have a licensed residential treatment for substance abuse run by one of the biggest treatment providers in Hudson County. They come into our jail, and they built a facility to treat. We have a one-stop, which is a job training center that provides trades training. It provides pre-occupational training. It provides hospitality training. We provide high school diplomas, basic education, literacy courses. Half of my staff, as I said, work for welfare, so they go in 30 days before somebody's going to be released. They sign them up for health insurance, Medicaid. We get them signed up for cash benefits, food stamps, and it's all activated the day they walk out. We have a federally qualified healthcare center within the walls of our correctional facility. We're one of few that have that, and Part of that means we have to share a doctor with that federally qualified healthcare center. We have to share medical records, and every patient that's seen by that federally qualified healthcare center in our facility also has to be seen by that federally qualified healthcare center when they're in the community. The reason why that's important is because this population generally uses the emergency room as their primary caregiver, right? And they only use the emergency room when they're in crisis. So you'll hear things like, well, the Affordable Care Act is great, but it's very expensive when applied to the homeless and to the reentry population. And that's precisely why it's so expensive, right? So if this population would get tapped into the primary care network and they would routinely check in on their chronic disorders, you would raise the level of care, and at the same time you would drive down the cost of delivering that care and sort of use the Affordable Care Act in a more responsible way. So when somebody is released, we provide housing, transitional housing in the community. It's just 90 days of housing until we can pass that person off to welfare, and then they can provide an additional 12 months of housing. So what we were working with was sort of like a 15-month window to get this person on their feet. Otherwise, the housing supports were going to dry up. And for a while, we were working in a silo, right? Reentry, the jail, working on its own to deliver services and not recognizing sort of like this housing department was out there that could sort of extend. We could sort of look to provide long-term housing, more permanent housing. We were providing case management. The courts have trusted us. They allow us to release inmates pre-adjudicated on a bracelet. They go into programming when they go for sentencing. The judge has a report card on how the client's doing in the community. You can use that report card to make a determination if it's going to be a punitive approach to sentencing or if it'll be more of a rehabilitative approach. We link to disability, and we try to keep them in sober housing as long as possible.
So, as Frank said, we really weren't coordinating too much until a few years ago, when there were specific individual cases that would come up that he had a really hard time housing. After the 15 months of assistance were over, he'd call our office. A lot of times it was probably too late in this process, and it just didn't really work. We tried putting some of our funding aside for reentry clients so they could go through a program that way, and that was fine, but you know, we knew there was a bigger need, I think both of us, but we didn't really know how to get there and how to expand that and how to really get the support from the county to do that. And so for us, the turning point really came over the winter, 2014 and 2015, when the county created a warming center in a facility right near the jail. And so, not knowing Hudson County, the bulk of our homeless population has been really focused in Jersey City and Hoboken, and the jail is out in Kearney. So while it's only maybe 5 or 6 miles away, it's like light years away for our population, because people don't really move and wouldn't go out there. And this building is located right next to the jail. And so we had a lot of community input and a lot of really active advocates who were saying that there were people on the street who didn't have anywhere to go. Our shelter system could not support them in the winter, and they were very upset about that, as were we. And so the solution that we all sort of cobbled together for that winter was to use this building that was owned by a nonprofit and just create a warming center. So it wasn't a shelter. We thought we could house maybe 50 people a night, and you know, not in beds. They had to kind of sit up because it wasn't a licensed facility. Yeah. And the way that the county decided to staff it was with corrections officers. And I, from my standpoint, thought that was the worst idea in the entire world. How are you going to put a bunch of homeless individuals that you literally have to bus over there, you know, convince them to get on a bus and then put them in a facility with corrections officers right next to the jail? Like, no one's going to want to do that or feel comfortable. I was completely 100% dead wrong. It turned out that our homeless population actually loved it. They felt very safe because they all knew the correction officers, because they had all been in the jail a lot. And the corrections officers actually really enjoyed it because they realized that they could help people in a better place and they weren't in jail. And so it was one of those situations where we had no clue it was going to turn out that way. We ended up serving that winter 75 people a night, which was way more than we ever thought we would do. And then Frank and I just kind of on the back of a napkin decided to run the names of everybody who had been in that facility and check them against our homeless system. And so, or check everybody who had used that system against the jail system. So we like individually looked up all these individuals in the jail. And we found out that the nights that they used the jail from the prior winter was about 2,000 nights in jail, but the prior winter, and then the winter we created the warming center was only 334 nights. So people were actually just going to jail less because they had somewhere else to go. And that was, for us, like we thought that of course that would make sense, but we finally had sort of the data to bring with us to our leaders as we, move forward to try to present a larger plan to work on this population. And from my standpoint, it was always about, again, permanent housing. And we can create a shelter, we can do that, we can do transitional housing for 15 months, but a lot of these people have much higher needs that are not going to be able to transition out of that transitional housing. They're going to need a more permanent voucher and subsidy. Ooh, so initially, our goal was to create a data match, and we were thinking big. We said we're going to get the hospital involved because we know they're going through the hospital, through the jail, and through the shelter, and we're going to collect all the names of all the individuals and put them together in a database and figure out who are the top utilizers of all of those systems. And we tried really hard at this for a while and realized it wasn't really going to be possible for a number of reasons, but mainly for accessing the data, HIPAA requirements, the hospital is just not really wanting to work with us. We have all the shelter data, or the homeless data through my office. There's something called the Homeless Management Information System. So all homeless providers are required to enter information into this. So we can pull a full report on everybody who's been in our homeless system. Typically, and across the country, normally you don't have access to the names at our level, but we were able to get that permission from our providers so that we could actually use that data and do something meaningful with it. And so, when it comes to the I guess we'll do that when you talk about the jail data.
Sure. So I think the biggest challenge is that, as I said, the population has needs across all domains, right? And every stakeholder that provides for this population is valuable, and they're going to deliver information to this program that we can use to make sure that we deliver care in the most appropriate way. I think the way to look at services for this population, like welfare and housing, is they're all set up as a general provision to be applied to people living below the poverty line, right? And what they don't do is they don't take into account the specific needs of these individuals or the subpopulations that exist in this general population. And the systems are set up in a way where if you sort of pay attention, you can have it delivered to this population in a way that meets their needs. It's just sort of paying attention and applying it, and sort of, the resource is there. It's just the way you apply the resource. So getting this information is essential to tailoring plans around this population: case management plans, housing plans, treatment plans, medication plans, and we hired a research person to come in and just do our data, and we figured the easiest would be the jail data, right? So we wanted to know who the most frequent users of our jail was. And what we found was, and we got this person access to our jail data information system, but the system can't be manipulated in any way. So it's difficult to explain, but you have to look up each person individually, right? And then you have to get their inmate numbers and go through each. So it's a tedious task to look at somebody's sort of past history. You just have to continue to sort of search that same person over and over and over. And the only organization that can sort of manipulate that data and run special reports for you are the Administrative Office of the Courts, which is run by the state of New Jersey. And for a little while, we were getting this report. We requested the report, and we were getting these reports on and developing sort of lists of our most frequent users, but for some reason, the Administrative Office of the Court said that we weren't authorized to have that list and that they were going to discontinue providing that list. So
we still don't have it.
Yeah. So where we are now is sort of piecing that frequent user together and using quite a bit of our time to just go through these people individually.
So what we did get was 5 years of data, which we may or may not have been allowed to have, but we have it. And so with that, we were able to cross-reference it with our HMIS system, and you could see the numbers there. So 5% of the jail population had experienced homelessness, and about 23% of our homeless population had been in the jail. And so those were not surprising numbers to us, but those were, it was just really nice to see that. So we still have that, and we're still kind of fighting to get that higher level of data. But we're not there. So what we ended up having to do is really, as Frank said, piece it together, do a lot of manual work, and just sort of start somewhere. And so when we first started having this conversation, we always had this dream, vouchers are going to come, housing's going to be available, we're going to be able to make this work. We have to prove it first. And so around the same time that we were doing this, we had the opportunity to apply for 27 vouchers through our homeless continuum of care process, through a bonus program that had to be targeted at the most vulnerable, chronically homeless individuals in our community. And so those vouchers were awarded to a nonprofit with service funding to support them. And what we basically did was, kind of backed into it and said, well, let's try to start using our jail data and target these vouchers to the people that are in the jail. And so while not all of them were in the jail, a number of them were, and these were really, again, our most vulnerable homeless in the community. And so that's been, I guess we're almost 2 years into having them all housed. And so this data has been what we've been able to use as we work to expand what we're doing. And so this shows, though it's kind of probably hard to see because it's small, but it's the before housing move-in cost. So we have 5 years of data from one of the main hospitals in the county, not the other. So it's by no means exhaustive at all. But we have the hospital data, our shelter data, and the jail costs. And we looked at what these individuals cost all of those systems, or 5 years before they were moved into housing, and then what they cost after. So the gray bar is before, and the orange bar is after. The jail costs were about $39,000, $40,000 before, down to $3,000, just about $4,000. So 90% reduction in jail costs once people were permanently housed with services. The hospital costs were more significant. And these are going down even more. This data is probably a little old at this point, and so we keep checking it, and we keep running it. And on, I guess, every 6 months, the data analyst in my office is running these against the jail. And the jail knows that these individuals are housed. So if they do end up back in the jail, they know that they can call their housing case manager and work through any issues with them and hopefully get them back into that housing.
I just want to, so I think when you look at the cost of jails, we should speak about this. You often hear that it costs between $40,000 and $60,000 to house somebody in a jail. And in Hudson County, we looked at things like social impact bonds and reducing the cost for corrections by providing services in the community. And what we found was the majority of corrections cost exists in the marginal cost, right? So the actual cost to house an inmate is about $16,000 a year in Hudson County, and the other costs represented by paying officers, paying overtime, turning the lights on, maintaining the facility. So the real cost savings that happen from programs like this exist within our healthcare network.
Yeah. And at the same time, the cost to permanently house somebody in supportive housing, it's about $25,000 a year. So that's significantly less than it costs somebody to be in and out of the jail. This is just some more data on just the overall cost, and obviously it's just a 47% reduction once people were housed. And then this is one of the individuals that was identified to be the most frequent user of both the hospital and the jail. And you can just see they didn't get back to the jail at all, and their hospital costs were significantly decreased. So our plan from there, and that was a very small pilot, was to really, and that was not targeted at people, the most frequent users of the jail. That was just happened to be people who were at the jail. And so we wanted to start a program targeted for frequent users of the jail. And we were very lucky that our state at that time had put out an RFP for 400 vouchers just for this population. We were awarded 100 vouchers in the county, which is the largest award that they made statewide. And I think that's mainly because the county really stepped up and came to the table with funding for the services. So in order to apply for these vouchers, you needed to show that you could provide $12,000 per person per month in service funding to support that, to pay case managers to go in and work with those individuals once they're housed. And what we saw across the state where people were just sort of cobbling things together, trying to fold this into existing programs and trying to make it work. And what we knew is that we needed something very significant and a real commitment. And so with all of that data and everything that we had collected on the back end and what we knew happened at the warming center and how that was really just a Band-Aid, Frank and I went to our county administrator and our freeholders and said, can we fund this? Can the county come up with the service dollars to do this? And
So, so what I'm most proud of our jail for is this project, and for this reason. There's a thing called an Inmate Welfare Trust Fund, and generally it exists. You'll hear an inmate say it costs a ton of money to make a phone call. It's a ton of money to buy like a thing like a bag of Doritos, and they'll say we're getting ripped off, and they're not lying. It is true, but the reason why it's there is because taxpayers aren't really tolerant of paying for things like cable TV in jail, weights, libraries. So the overcharging goes into this thing called an Inmate Welfare Trust Fund, which is controlled by the state, and each county has their own sort of trust fund. And the money can be used as long as you can demonstrate that it's going to be used, or every inmate in that jail has the benefit to use it. So we pay for our drug treatment with it, we pay for One Stop, we pay for educational services, and there was a cash match for these grants at $1 million, and the jail is paying. So what the jail is, we convinced the state to allow us to use the $1 million out of the Inmate Welfare Trust Fund. So the inmates are actually paying this themselves, and it's the jail paying to build permanent community housing outside of its walls to make sure that its frequent users don't come to the correctional facility, right? So I think that's where our jail is most progressive. And I just want to talk about why this is so important now in New Jersey, because we have a thing called bail reform, right? So what bail reform is it's presented as a moral issue, right? So if you're making $30,000 a year and you go to jail and you have a bail of $5,000, you're going to be able to bail out and go home. But if you're homeless and you get a bail, you're not going to be. So it's a way to even the playing field. So if you have a history of nonviolent criminal acts, drug charges, what they do is legally you step foot in our jail, and legally you have to be released in 48 hours. Now the problem with that is the assessment that they use to determine if somebody's going to be released on bail reform only speaks to criminal history. So it just looks at the person's criminal background. It doesn't look at mental health issues, primary and secondary attachments, drug issues. So what's happening is the very population that the jail was serving, or our reentry target population that sort of was enrolled in all our programs in the jail, are coming in physically addicted to opiates, and they're walking out of our walls within 48 hours. They're not there long enough to get them stable anymore, to sort of look at the systemic cause or the illnesses that are driving the behaviors. So they're cycling through. They come in high, they come in physically addicted, they come in homeless, and they walk out in the same state. And what we have effectively done with this program is sort of build a diversion program. We've sort of identified who our most frequent users are, and we've created ways to identify them before they have even gotten to the jail, and to apply services to them before they come to the jail. And what we found is this is a really a good way to combat sort of that quick cycling through our correctional facility, and our ability not to get our hands on them while they're in our correctional facility.
Yeah, so this is just a little bit about how we prioritize people for the housing. It was a challenge. It took us over a year and a half working with two really good housing homeless providers in the community to basically identify everybody on the list. We started with the jail telling us, because we couldn't get the jail data from the state the way we wanted, which we would have been able to just cross-reference and know who had been in both systems the most, we had to do it manually. So it took a lot of time. It started with the jail identifying who they thought was who were their highest users, giving us those names, all of our homeless clients who had signed release forms and were in our coordinated entry system, running those lists against each other, checking those that were most vulnerable, how many times they had been in the jail. And we started with a really different population than we thought we would. It took us a while to identify the full. We ended up using 80 of them in the time we had allowed by the state. And so probably just last month, we housed the last one. It took really, I guess, a year and a half from when the first one was housed. And so it's a challenging population. Our providers are really enjoy working with this population because they know that they certainly need the help. I will say it was not easy, and we continue to have challenges just with the way that all of us work differently, and when we come from the housing standpoint and how our providers are in the community and how the Department of Corrections and Rehabilitation works, it's just very, very different mindset. So there's times where we're all butting heads and it's not necessarily working, but what I can say is that for the most part, all these individuals are still housed and doing really well, and I think we've all had to take a step back and try to understand how each other's system works and get outside of our own bubble and what we're used to. And I think a lot of people had said that in the last session, of the words that we use and the terminology and all that, and just understand that there are different ways to think about it, and we need to use each other to work together, because we would never have been able to do this without the partnership. And so we got our 5-minute warning, so we'll wrap up. Our next step is really to partner with the hospitals. We, with all that data that we shared, we're able to go back to the hospitals and say, look at these individuals. We can give them their names. They can look them up in their system and say, oh yeah, they really have not been back here. And so tentatively, we've gotten some of our hospital systems to agree to actually pay for the services. So just like the county was paying for the services for those targeted for those in and out of the jail the most, the hospitals, which is really, I think, the first time in New Jersey this is going to happen, they're actually going to put cash out to pay for those services, and our state is going to work with us on a pilot program to house them. And we know these individuals have been in and out of the jail as well. And so we'll be able to continue to expand this. And really just keep looking at our data and making sure, and it's not just about cost, I think it's also making sure that, quality of life is better for individuals, and looking at how we can measure this program and report on the success as we move forward. And I think you already really talked about bail reform and what that means. So there's been a lot of challenges with that, and I think our homeless providers and the hospitals are seeing homeless individuals much more than they ever used to. And I don't know if you want to share the story about the...
Well, so I think frontline law enforcement is using the jail less. There's a good story that can sort of illustrate what's going on. So we meet with the hospitals routinely and the outreach centers. And last month they said opiates isn't the issue. The crisis now is PCP. There's a new issue with PCP in Hudson County. And the jail has always known that there's a huge PCP issue. The problem is when somebody's high on PCP, it's a behavioral issue when the cop responds to it, and usually the person is arrested for being high, and the jail has been charged historically with dealing with people who are high on PCP. But when the cops react now because of bail reform, they're not taking them to the jail. They know they're going to float through within 48 hours, so they're taking them to the hospitals and the outreach centers. So it's just hitting their radar, this PCP issue. So what that tells us is that the police are looking for clinical options. They recognize that there's better options than the jail, and that to properly, sort of augment behavior in a population that's addicted to drugs and in a mental health population, you got to get them stable. The healthcare network is the right place to go, and I think this program is demonstrating that, if we can work with our outreach centers and these other programs and then get them housed and then provide case management, the jail might not be the right audience for this, the right place for this population.
Great. Thanks to all our presenters. Please give them applause here. So we have about 10 minutes for questions and answers. If you want to speak, please raise your hand and a microphone will be brought to you.
I'm Dwayne Merritt, County Commissioner from Stearns County, Minnesota. These are all great programs, and I've listened to these for the last number of years, and good presentations in the first session and this session. Is there a way that we can quantify the savings by these programs? It is difficult to implement some of these when you talk to taxpayers back home and you're spending money on some of these programs. Is there some way, somehow, that somebody, some organization can put something together that says, these are the dollars that we save by implementing these programs?
So what I will say is the savings are complicated, right? They don't just exist in one system, and they exist sort of in private hospitals and in government and through Medicaid, which is a federal benefit, and so they exist across different systems. These systems we either don't have access to or they're guarded. But I will say this, that in New Jersey we're an expansion state, right? So and prior to the Affordable Care Act in New Jersey, somebody who had a drug charge was precluded from receiving Medicaid benefits. They were banned for life. If you had a distribution conviction for which you served 6 months after 1996, you were banned from life receiving Medicaid. And then what happened was the Affordable Care Act came, and the only qualifier for Medicaid was income level. And as a matter of fact, they expanded the amount of money you could make to get Medicaid. And this will demonstrate that there are savings. So the population, a large part of this homeless and reentry population prior to this weren't eligible for Medicaid, and now they are. And the health insurance, Medicaid is just provided by health insurance companies, regular insurance companies. And they use calculators. They put somebody's variables in and they say, this is how much it should cost to deliver health care to this population. And what they were finding was with this population, the amount of money they were spending on health care for the reentry was just off of the charts. It just wasn't what they anticipated. And the reason for that was because you're giving somebody health insurance who's never had health insurance before, but that's not the answer. The answer is giving them that health insurance and then teaching them how to use that health insurance. So I think if you're looking to sort of find where the savings are, things like the insurance companies that who deliver health care to this population, you get the names from your welfare agencies, whoever delivers your Medicaid benefits, and then you speak to those health insurance companies and you look at what they're costing those health insurance companies.
And on the housing side, the Corporation for Supportive Housing has a lot of data on various, they call it their FUSE initiative, the Frequent User System Engagement Initiative, FUSE, that there have been large studies across the country focused on this. So they have a lot of stuff on their website.
Awesome. Hello, Spencer Graves, Pima County. We have a program looking at homeless housing for those hitting our jail multiple times. One of your prioritizations, it was looking at those with the highest number of recidivism and low vulnerability. I was wondering if you guys use VI SPDAT. If so, how do you guys prioritize? Because I was thinking highest needs would be more to the top, but.
We don't. When we started our coordinated entry program for our homeless system, we looked at a lot of different assessment tools. The VI SPDAT was really popular at the time, and I sat through a conference, thought it was great, gave it to our provider. They looked at it, and they tried it for a couple months and actually really did not like it. And so we've moved on to one that they've been using for the last 4 years, I guess, where it's based on a tool out of Arizona, but they've fixed and kind of changed it and tweaked it a bit. So it's really just kind of our own unique one. We'd be happy to share it, but it seems to work really well. It's a scale of 25, so I don't know what it goes. Anybody under 25 is our highest vulnerability. And then on the jail side, it was at least 2 times in the last 5 years.
So in one of your other graphs, you showed 5% that was overlap who were homeless individuals. Can you talk a little bit about what was your indicator? What did you use to determine someone was homeless? Was it the HUD definition, or was it general delivery address? Was it?
It was people that were in our homeless management information system database. So anybody who had touched a shelter, an outreach program, coordinated entry, had been in a transitional housing program. So anybody who had utilized our homeless system would have been entered into that system. So we had the raw data from that we cross-referenced with the jail data.
Good morning. My name is Craig Matthews, and I'm from the only place in the United States that has parishes, Louisiana. And I'm very reluctant to say that, of course, you know Louisiana is the #1 state in the country for incarceration. And I want to address, I guess, a sort of a comment and question to the Sheriff Vick. In one of your slides, you said jails are the #1 providers of services for mentally ill individuals in I guess, that county. And it's it's a little different set of dynamics in Louisiana particularly. Jails are not the #1 provider of services for mentally ill individuals. It's the #1 provider of housing for mentally ill individuals. And what I mean by that is I found your discourse very interesting, that you have somehow managed to create a comprehensive set of strategies and objectives to assist and provide services to that population. And of course, you know, we know in many parts of this country, incarcerating individuals has become big business, particularly in Louisiana. So we're now in a situation where our state legislature has attempted or is attempting to revitalize and reform some of these elements of the criminal justice system. And I'm just very curious to know, how did Tulsa derive at that type of funding to be able to implement comprehensive services that would facilitate some type of transition for those mentally ill individuals that you all were housing that eventually began to receive services?
So let me kind of put this, is this on? We face the same issues that I think that you're talking about. We've cut millions of dollars from treatment and in particular the mental health arena in the state of Oklahoma, therefore creating what I've talked about being the largest provider of mental health care in the jails. And, you know, to kind of put that in perspective, when we opened in April of 2017, by the end of April of 2017, we were at max capacity. And what I found interesting was that jails and even other facilities that were non-jail would call our center and say, do you have beds available? Which was interesting because somewhere, somehow, we became known as a mental health facility and not mental health detention, which I think what is interesting about that, and I think should be pointed out, is the sad state of affairs of mental health treatment in particular the state of Oklahoma. Now, in terms of funding and resources, like I mentioned and touched on, it's imperative that public and private partnerships are facilitated. You know, and kind of a prime example of that is, and I didn't mention it during my little presentation, but what we hope to get to within the next 5 years is a one-stop shop assessment center where law enforcement, medical, you name it, can come. It's a short-term stay, 12 hours, nothing overnight, but what we do is hopefully provide housing, mental health resources, treatment, you name it, homelessness. And it's going to be astronomical in terms of the money that it's going to take to run such a center. And we've received commitments from several private donors, for lack of a better term. So again, money, funding, all those things seem to be the obstacle, apparently in Louisiana, Oklahoma, and I would venture to stay, as well as the other states that are represented and counties that are represented here. And again, in closing, I think it becomes imperative to facilitate, educate, and foster those relationships in the public and private sector. I hope I answered your question. Okay, all right.
Okay, I think, sir, I know you've been waiting. No, in the back? Okay, I think we are done with questions. Okay. Well, thank you all. Let's give our presenters another round of applause.